Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. And thank you all for joining us today. And a thank you to Clinica Sierra Vista in the Central Valley of Southern California for requesting today's session. Today, we're going to be talking about polymyalgia rheumatica with Dr. Justus Fiechtner. Dr. Fiechtner is a rheumatologist who has worked in a large multi-specialty clinic as a hospital employee and as an owner of a single specialty private practice. He has been affiliated with university teaching programs as a teacher, professor, and mentor to students, residents, and fellows. He and his wife Carlene live in Okemos, Michigan, and have children and grandchildren in Boston and Western Michigan. So I'm going to go ahead and share the slides, and then I'll turn it over to you, Dr. Fiechtner, in just a minute. And I'll just say that none of the individuals are in a position to influence the content. And this is about MAVEN accreditation. And I'll turn it over to Dr. Fiechtner.
Thanks, Jill. So we're going to talk about polymyalgia rheumatica, PMR for short. These are the basic goals for the talk. You should be able to recognize patients who have polymyalgia rheumatica by the basis of history and physical exam. Should be able to discuss the history and epidemiology of PMR, recognize predisposing factors and concomitant diseases, and then discuss pathophysiology and treatments. Next slide, thank you. So, diagnostic criteria for polymyalgia per the American College of Rheumatology include these. One is the age of onset of 50 or 50 years or older. I have seen occasional person with this under the age of 50, but almost all are above that. Sedimentation rate should be at least 40. And again, that's a give or take. In clinical practice, you might end up with somebody with a little bit less. And remember that sed rates have to be done within 2 hours of drawing the blood, which is not always the case, unfortunately. So sometimes you have to repeat the sed rate just to make sure you're accurate. Pain should be persistent for greater than a month and involving two of the following areas: neck, shoulders, and pelvic girdle. Absence of other diseases should be proven because many things will cause that type of musculoskeletal symptom. The morning stiffness should be prominent and last for at least an hour. And really, the sine qua non for the diagnosis is a very low dose of corticosteroid will make the symptoms disappear almost overnight. Next slide. So, how often do you see muscle pain in the shoulders and hips? Almost always. Profound morning stiffness? Almost always. Fatigue? Frequently. Temperature elevation? Not very often, but sometimes. And occasionally you will see some distal extremity changes, including pitting edema. But that is pretty rare and could certainly suggest maybe another diagnosis, for example, rheumatoid arthritis. Next slide, please. So usually on physical examination, the patient is not noticeably weak, and you don't see any specific muscle atrophy. But when you do passive range of motion, shoulder and hip, even with active range of motion of the shoulder and hip region, it's going to be painful. Occasionally you'll see some changes at the knee. As I mentioned before, you might see some peripheral joint changes, for example, at the wrist. And occasionally you'll have tenderness at the sternoclavicular joints. And I mentioned that there might be a peripheral non-erosive type arthritis noted on occasion. You will see some, you will note some tenderness to palpation with increased passive range of motion in the musculature of the proximal hip, leg and shoulder arm girdle. Next slide. So you need to think about other things that might be causing these symptoms and signs when you do the examination. Of course, acute or chronic infection can certainly cause a high SED rate, and as can many other things. They might have, in fact, a bad infection like the endocarditis. Bursitis and tendonitis can easily be confused as well, but usually that's going to be localized to just one or two areas. It's not going to be this generalized sensation in the shoulder and hip region of pain and stiffness. Osteoarthritis or spondylosis of the neck certainly can give you the upper back and shoulder symptoms. Dermatomyositis is something to consider, but you're going to see muscle weakness, and this should not have, you should not see muscle weakness with polymyalgia. And then, of course, malignancy can emulate almost anything, so you have to always keep in mind your patient population and risk factors for other things. Next slide. Just any myopathy in general could be considered, but again, the muscle weakness has to be there. Parkinson's disease, hopefully, this would maybe be in the early onset of Parkinson's, but not in advanced cases where you would see the typical changes you see with Parkinson's. There is a thing called RS3PE, which is remitting seronegative symmetrical synovitis with pitting edema. And don't say that over and over too many times. But again, you should not see the peripheral synovitis maybe on a rare occasion, but you will also have all the other symptoms of morning stiffness, high SED rate, etc. And that should rule out the RS3PE. Just shoulder problems in general. Certainly, I mentioned tendonitis, bursitis before, but any of the shoulder symptoms you have to be aware of. Be aware of whether or not they had a recent injury, or if this is a really chronic problem and didn't just happen recently. It could be CPBD, that's calcium pyrophosphate deposition disease. But again, you're going to have acute flares like you do with gout. So that should probably not be too confusing a diagnosis. Ankylosing spondylitis, that's a possibility. Generally, ankylosing spondylitis will manifest itself in younger patients, but occasionally we do see some showing up in older patients. And that they can give you very similar symptoms, certainly of morning stiffness and pain in the areas that I mentioned, especially the neck, shoulder, and hip regions. And the last one is very important because people with polymyalgia rheumatica might also have giant cell arteritis, which is a diagnosis you do not want to miss. And that's something you have to consider in every single case of polymyalgia. And giant cell arteritis, of course, is inflammation, which is mostly manifested in the scalp, tenderness of the temples. They might have jaw claudication. Their sedimentation rates and the CRP were going to be generally much higher than you'd see with PMR, but you can maybe have some overlap there with the numbers, but this is something you need to always consider in somebody who has been diagnosed with polymyalgia, because the initial symptoms are very similar. But again, as I said, there's a localization, particularly into the scalp, jaw, etc., with GCA. Next slide. Here's a few more. Amyloid, always a tough diagnosis to make, although I've heard that there are some new tests that might actually be helpful. Certainly patients with depression will often have pain, and people with pain will often have depression. But again, that's going to be more of a chronic problem. Same with fibromyalgia. You're going to be seeing that over the course of 3 months or more. Whereas with PMR, the patient almost says, I was fine yesterday, and when I got up this morning, I could hardly get up this morning because I was in so much pain. Which has kind of led to some of the questions as to why people get polymyalgia. And it's been thought that maybe it's a viral trigger in a genetically susceptible individual, but that is yet to be proven. I mentioned the giant cell arteritis, also known as temporal arteritis. People with thyroid disease, especially hypothyroidism, certainly will have the fatigue, and they tend to get aches and pains as well. So you might have to consider that, and it's at least worth doing a blood test to rule out. Next slide. Multiple myeloma, that's another one you don't want to miss, but they will have some similar symptoms. The SED rate's also going to be sky high, so it's something to consider. Osteoarthritis, we all get that. Everybody over the age of 50 is going to have osteoarthritis, but it's going to be generally localized to one joint or two. It's not going to be this shoulder, hip, girdle type symptomatology, not rapid, overnight onset, etc. Paraneoplastic syndromes, again, just like any malignancy, you might want to keep that in mind. I mentioned before polymyositis, but that's going to be seen as causing muscle weakness. And the patients in polymyositis generally do not have a lot of muscle pain. And then there's rheumatoid arthritis. I mentioned that before. You're going to see peripheral joint problems with that, much more so than you would with PMR. Next slide. So what laboratory tests do you look for? Well, you want to think about other diagnoses. And really, the only blood test that is going to be remarkable with PMR is going to be the SED rate or the CRP. So that's that the rheumatoid factor is obviously there, and the CCP would be done to look at the possibility of RA. Then I mentioned the CRP and SED rate. CBC should probably be done and then blood sugar to make sure there's not a diabetic component. Creatinine for renal disease, LFTs, and calcium and alkaline phosphatase. You might want to look at that in a rare case that you might see somebody with Paget's disease, for example, presenting with these symptoms. And also, again, looking at renal dysfunction, a dipstick analysis. Next slide. So a couple of other tests you might want to think about specifically for multiple myeloma or for amyloid protein electrophoresis would give you a better idea if that's a possibility. Thyroid function test, the TSH, specifically for hypothyroidism. CPK would be looking for polymyositis, and then vitamin D level, potentially you might have a vitamin D deficient patient with some similar symptoms to PMR. Next slide. Okay, treatment, as I said, the treatment is often diagnostic in that using a very low dose of steroid prednisone, we're talking about here, 15 to 20 milligrams, within a short period of time, the symptoms are going to go away. But you have to keep in mind that if the symptoms don't go away and you find yourself increasing the dose 30, 40 milligrams or more just to get some benefit in the symptomatology, then you have to start thinking about giant cell arteritis or temporal arteritis. especially if they're having problems with headaches, jaw pain, visual impairment, and as I mentioned, a much higher SED rate. Now, the big problem with treatment of polymyalgia is getting the patient off the steroids. So we anticipate that a patient with PMR is going to get to the point where they won't have to take any steroids within 8 to 12 months. And in my practice, I certainly saw lots and lots of people who were on these I mean, relatively low dose steroids, 5 to 10 milligrams perhaps daily, but they'd been on it for like 3, 4 years. Now, that is clearly not desirable, and mainly because of the problem with bone loss and causing osteoporosis. But just the use of steroids alone are known to increase the risk of cardiovascular disease as well. So, the big goal for your treatment is once you got the diagnosis and you got them on the low dose, you have to say, well, how am I going to get them off this? So a rule of thumb is that approximately once a month, you decrease the dose, and very, very slow, gradual reduction by 1 milligram per month is recommended. At the same time, you're going to be monitoring their SED rate specifically. There's always a conundrum. The SED rate goes up, but the patient feels fine. Keep in mind that the patient's symptoms are probably a little bit more important than the SED rate. So you don't want to keep chasing that SED rate by bumping up the dose of steroids all the time. So you have to have both the recurrence of the symptoms as well as a high SED rate, and not just an elevated SED rate. So you have to use clinical judgment in order to maximize your steroid use. What if you can't get them off the steroids? Well, we do use disease-modifying drugs, including methotrexate. And in some cases, when I know there's going to be a problem, I'll initiate methotrexate pretty early in the course of treatment. And so I think it's something to keep in mind. I know a lot of you are getting comfortable with using methotrexate because it's so hard to get patients in to see rheumatologists these days. And a lot of consults that I've gotten from you have included instructions on how to use methotrexate. And usually, what we try to do is start with a low dose, 7.5 milligrams per week. You take them all 3 pills, which are 2.5 milligram pills, at the same time once a week. You supplement with folic acid to decrease the possibility of side effects from the methotrexate. And then you can slowly increase the dose if you need to. I generally would not allow or recommend using more than 20 milligrams per week total of methotrexate. But you shouldn't have to use quite that high dose for polymyalgia rheumatica as you would for RA, for example. Excuse me. What about the use of NSAIDs? I think NSAIDs are helpful in allowing you to reduce the corticosteroids. And usually I like the longer acting ones, particularly taking them in the evening so that patients are not so stiff and sore when they get up in the morning. So that's a good option as well. Topical NSAIDs, you have to keep in mind, a lot of people do respond well to those. And if you if you can, there are stronger doses of the Voltaren topical that might be soon available in the US. They are available already in Mexico and in Europe. And you can also use compounders to, I used to send my patients to compounders for 5% Voltaren, and it is helpful. Tocilizumab is approved. That's an IL-6 drug which could be used intramuscularly or subcutaneously, I should say, or IV. And that is approved for polymyalgia rheumatica. It's also approved for giant cell arteritis. And it's very helpful in getting patients off steroids. There has been a recent also approval of a JAK inhibitor for this. Unfortunately, recently JAK inhibitors have been noted to possibly increase the risk of cardiovascular disease in older patients. So I don't know whether their popularity will go down, but certainly people would rather take a pill as you can with the JAK inhibitors versus injectables. Next slide. So hopefully you'll be able to get your patients off steroids within a year, but you have to keep in mind that these patients are at increased risk for osteoporotic fractures. So you must be supplementing with vitamin D. You do need to do a bone density test to look at their baseline to make sure that they're not going to really get in trouble with the steroids because of it. And if you do make a diagnosis of high risk uh, for fracture, and that's not just osteoporosis alone, but looking at bone density numbers plus risk factors, then you will supplement with some kind of medication to prevent the fractures, including bisphosphonates. I mentioned this before that you need to trust the patient's symptoms probably more than just a mild change in the SED rate, because the patient's symptoms uh, seem to be more important, and it's easier to get patients off steroids if you're not chasing the SED rate every time it goes up a little bit by increasing the steroid dose. It is important to have patients on a strengthening exercise program. It's very tempting when you hurt to not want to exercise. So, and you do lose muscle strength as a result. So I always strongly emphasize the strengthening program. Uh, Obviously, particularly for the muscle groups, the shoulder and hip regions. Next slide. So I have a case history here. We have a 72-year-old with a history of osteoporosis, hypertension, uh, presenting with recurrent morning stiffness and pain in the shoulders and hips over the last 3 weeks. She was diagnosed with polymyalgia rheumatica 14 months ago and initially responded well to prednisone 15 milligrams daily. So as I mentioned before, this is the kind of patient I used to see, that they are still on steroids longer than you'd like them to be. Her symptoms improved within days and SED rate normalized after starting 15 milligrams. Prednisone was tapered gradually over the past year, but at a dose of 5 milligrams daily, stiffness and fatigue returned. So this is the patient you might want to consider using another medication to help bring the steroid dose down, including, as I mentioned before, possibility of methotrexate. She denies any visual symptoms, headaches, or jaw claudication, and there we're talking about the giant cell arteritis that you must always consider with these patients. So the medications at this point are prednisone 5 milligrams. The patient is on alendronate for osteoporosis, but as I said, you have to even consider it as a preventative before they get the osteoporosis if they're at high risk. Also on amlodipine, simvastatin, calcium and vitamin D supplements. On physical examination, patient with bilateral shoulders, restricted range of motion, and pain. And that's why they have the restricted range of motion, because when you get to a certain point, it hurts. Same thing with the hips. No peripheral synovitis. And in this patient, there's no temporal artery tenderness or scalp tenderness. Next slide, please. So the SED rates come back like this. SED rate 62, CRP is high, CBC panel and CK are normal. So what do you do? It's obviously tempting to increase the steroid dose with a high sed rate like that. But again, you have to consider the symptoms, and this patient did have increased symptoms. So you might have to bump it up a little bit, but you don't want to, go too high. She's only, or he or she, I guess it didn't really say, uh, go above 5 milligrams to up to 10 milligrams, see if you get a response, for example. But over time, if you have trouble getting the steroid dose down, then you have to consider something like methotrexate or possibly use a biologic like tocilizumab or a JAK inhibitor. Next slide. I think that's probably it. So, in summary, you're going to see this type of patient frequently in anyone who is older and has these symptoms. You certainly must suspect polymyalgia rheumatica, and easy enough to treat with a low dose steroids, and they should get an almost immediate response. The other thing that you have to keep in mind is you don't want to miss a case of giant cell arteritis. Recently, my brother, who's a physician, um, and who should know better. No, he's older than I am, so I give that as an excuse. But so he has had symptoms or had symptoms for, I don't know, months, and mostly hip pain, but then started to develop pain in his jaw. He went to see a dentist, and they didn't really find anything. Um, I suggested he go see his physician and get some blood tests done for inflammation. And sure enough, his sed rate was very high. And he happened to be visiting uh, his daughter and my my daughter, who both live in Boston. And he conveniently fell out of bed. And so it ended up he went in uh, to the hospital, and they did a sed rate, and they figured out that this guy has got some difficulty. And unfortunately, at that point, he also noticed visual changes. He had lost vision in one eye. And that's unfortunately too late to make that diagnosis of giant cell arteritis. He's done well with treatment, and he's on tocilizumab now. But I kick myself every time that I think about that. But there's nothing I could have done. He lives a long way from me, and I couldn't exactly tell his doctors what to do at that point. So don't miss it. Okay.
Great. Any final words, Dr. Fechner, before we leave?
Well, as I said, I think just being aware that this condition exists, and because this is a nice disease to treat, that because patients get better quick. And then, as I said, the problem is getting the patients off the treatment, but it's very doable. And then the secondary thing is not to miss a giant cell arteritis patient, which will have similar symptoms in addition to others, specifically the headaches and jaw claudication. And on exam, they have temporal artery tenderness or tenderness in any scalp vessel. I've seen posterior vessels being the culprits. So I guess that's about it.
Wonderful. Well, thank you so much again, Dr. Fechner, for presenting today. Thank you to all of the providers for being here, for asking such great questions. And a huge thank you to all the providers for taking such good care of your patients and really being there for them. I know that you are much appreciated, and we appreciate you and the jobs that you do. So I hope everybody has a great rest of their week, and we'll hopefully see you at our next session.